presentation this afternoon. It's a pleasure to see most of you here. So in this session, we are going to be discussing how we can invest in our future by providing a comprehensive agenda for children and adolescents. They say that what you invest is what you reap. So if we have to invest in our future, we need to invest in the generation we are producing today and making sure that they grow up optimally. In this session, we thought it would be good just to give an overview of what does it mean to provide a comprehensive agenda, but also to hear from the countries that are trying to implement this, how they are transforming the health systems in order to actually deliver on this comprehensive agenda. And we shall have some opportunity to have some dialogue and discussion from that. For us to achieve the objective of the session, there will be some presenters. I'll be giving an overview myself in terms of what does WHO say today and why are we saying this. And then we shall hear from Indonesia, the experience from Indonesia, from Dr. Ingram, who will be giving us some experience, what they are doing and how they are integrating this in their system. And then we shall hear from Dr. Saki Nakamura, who will just give us also the experience from Japan on how this is being done. And then we shall hear from Dr. Surat from Thailand, who will also give us details of how they are managing their programs in Thailand. And then we shall have some discussion from Tomoko Hattori to give us some overview after hearing all this. And after that, we shall have Robinson give us some room to discuss and ask questions and provide input in the session. So that's how the program is going to go. And I think we started this early this morning. Those who are here this morning saw what is happening in some countries. This afternoon, we are continuing with some of these because they are really linked when you talk about home-based records. We shall have another session after this. So I'll just give now an overview of what WHO and UNICEF are telling us about how to start a comprehensive agenda for children and adolescents. And basically, I'll just give why is this becoming very important and why do we need to shift in the way we are doing things today to approach and put children and adolescents in the center, but at the same time also making sure that we are providing them what they need to grow and become optimally healthy. And then what's the role of well care visits in that? So first of all, I think we have a very good background on this. One is that there's a political endorsement that gives us the SDGs that are actually quite comprehensive. When you look at the SDGs, the way they were designed, they're actually for human capital development. And if that is really the direction, how can we respond from our side as the health sector? And this was actually defined in our global strategy for women and children's health, which looks at making sure that the children, women, children, and adolescents are able to survive, but also to thrive, but also recognizing that there are many aspects that we can use to transform the services, but also optimize and innovate so that we can achieve this agenda. At the same time, over time, we have elaborated a lot of frameworks looking at the early childhood development framework, nurturing care framework, the adolescent health and well-being framework. All those give us opportunity to say, how can we translate this in action? And this is why we are thinking it's time for us to move forward. And then we are talking about universal health coverage within the context of primary care that gives us really the systems that we can deliver all this within an integrated service. So with that, then we need to shift. And what are those shifts? Over the years, we have focused so much on disease, on morbidity and mortality. We need to move to how we can optimize health. At the same time, also recognizing that still there will be children that will need to be supported, whether they are ill or they need to be rehabilitated to optimize their health. We need to recognize that. So the systems should be able to address all these aspects. We are not saying that they just move from one direction to another direction. But to do this, we need to change our programming so that we look at how to look at these children even before conception until the first 2 decades of life. And to do this, WHO and UNICEF elaborated what we are calling comprehensive agenda for children, for children's health and well-being. And in here, we took a perspective of saying that we should be looking at developing the optimal health, developing human capital for the population, rather than looking at children as people who are going to fall sick, and we design systems that only help them when they are sick. And here we want that children can become healthy, grow optimally, and be in a safe and secure environment, but also be prepared physically, mentally, socially, and emotionally to actually be productive people in society. And I think that's what every parent aspires their child to be. They don't aspire for them to fall sick. They don't aspire them to be useless in the community. Everybody aspires for that. But how can we actually support this aspiration for the parents? So these are the shifts we are calling upon, that we do a life course approach to programming. I will explain that later. But also focus on survival, but ensuring that we are able to also give adequate health and nutrition and psychosocial support to these children. At the same time, trying to refocus the system to build resilience in these children and adolescents rather than, like I said, looking at disease. So just to fall back a bit to say that healthy development is actually influenced by a lot of multiplicity of factors, who your parents are, where you are born, where you live, actually really influence the outcome, what you are going to do in life. And that is a fact of life that we should know. And these aspects actually are very, very important. So when you put a child and adolescent in the center, there are many factors that are actually influencing their health and well-being. And those factors are very paramount for us. They interact in order to shape how the child is going to develop. And so it is very, very important that we understand those factors. And today, I think we know many of these factors and we can actually influence them. So why are we focusing in the first 2 decades of life? I think one thing is that whatever happens, even before you are born, will actually impact on your health lifestyle, even in adulthood. And I think that's very, very important, that whatever you do will be linked as part of the outcome. The risks you go through that either protective or those that cause you problems are going to influence the outcome. And of course, like I said, we have a better understanding and what we can do to actually change trajectories. In order to do that, we looked at the nurturing care framework and also the adolescent health and well-being framework, and we identified 6 domains of action. And these domains of action are very critical. And I can say that even as an adult, these are actually the critical domains of action that you need for you to be healthy and well. So these domains of action is where we should all act in order to help children and adolescents optimize their health and well-being. But what does it mean actually when you start now moving towards putting it in practice? So there should be those actions or interventions that are universal, irrespective of where the child is, that they should receive them. Just like we say you should immunize, every child should be immunized. Doesn't matter where that child is. So if you look at all these domains, all the actions we should take, there are those actions that every child everywhere should receive. However, we should also recognize there will be children who will need extra support. The simple one I can say, if a child falls sick, then he needs acute care, because otherwise you will not be able to help them. Or if they have a physical or disability, then you need to rehabilitate them to optimize their health. Or if they have a social problem, they need to be managed, because that social problem will impact on their health and well-being. And in order to do that, then we should also recognize that the actions can only be taken in many places, not only in one place. In the family, within the community, within the spaces these children are most of the time. You know, the first 5 years of life, probably most kids are around their families. But after they start going to go to school, they spend more time at school. So that platform is very, very important for us to utilize to do that, to deliver the services. And we also need to recognize that this cannot only be done by health sector. Other sectors are very critical to delivering this. And I've just highlighted some of the sectors that are important, but you can see that all sectors actually will need to contribute. And like I said at the beginning, SDGs help us to put this together, because in most countries, if SDGs are helping design the investments of countries in human capital, I think then we can leverage them. So why well-care visits programming is very important? Because we think this is an opportunity where we can actually deliver this in practice. You need to have a system in which you can actually deliver health rather than waiting when people only come when they are ill or when they have a problem. So in order to do this as a health sector, we need to have a system where we can deliver this, where we can come in contact with families and their children and adolescents. So we recently released a guidance, a general guidance around well-care visits. And this really says, it gives an outline of the rationale and objectives for that, but also proposes a minimum. This is just a minimum of 17 visits that you can actually be able to deliver this. But each country can look through what they can do and be able to do that. At the same time, we also recognize that what can be done in several places. So we also put some information on what you have to do at the time of each visit. And that document is already published and accessible. You can get it on the website. And here we are encouraging that these visits be scheduled to promote health and healthy behaviors, but also be an opportunity to observe the progress of how the child is developing and if there are any problem, whether physical, mental, social, psychological problems. But also an opportunity to intervene if they need immunization, they need any other actions they can be done, but also to identify whether they have any risks, any problem that you can mitigate before it's too late, but also identify those that need extra support and be referred or be supported to grow. And these are the transition periods we looked at, and building on existing visits, we just looked at what other visits will be critical in order to improve on the contacts. And so this is how we came up with those 17 visits, and these 17 visits are organized in a way that these are transitional periods that these children are going through, that you need to be able to see whether the family or the caregivers and the children themselves actually know what they are supposed to be doing for their health and well-being. And of course, then there are actions. What actions should you take at each visit? So it gives you details of what you should do at each visit of those 17 visits. And then lastly, just as an example, so why at 6 months? At 6 months, because we thought that's the time when a child, for example, is transitioning from exclusive breastfeeding and is now going to start complementary feeding. I think it's important at that juncture, the parents know exactly what they are doing, and then you can have an opportunity to discuss with them and see whether what they know is sufficient for them to do a good job, or to support them and encourage them what they are doing. But you can see that all this is also organized in a way that we look at the family, we look at how you assess, what you counsel in anticipatory purposes, and actually what you can intervene at each visit. And then we also recognize that there's a situation where you pick up something, then you have to make sure that there's continuity of care where you take these children. So this is how this guidance is organized, and we are hoping that countries can build on the existing work they are doing, and we are hoping to hear from the colleagues from other countries to share this information. Thank you very much. So now we are going to hear from colleagues from countries who are going to share with us the experiences. We shall start with Indonesia to share the experience, and so after that, then we shall have the discussions like I said. So please go ahead.
Good afternoon, everybody. It's my honor to join in this session. Thank you for JICA invite Indonesia to Nagasaki. My name is Ningrum. I'm from Ministry of Health Indonesia, Directorate Nutrition and Maternal Child Health. I would like to talk about effect of the integrated child health checkup in Indonesia on enhancing caregiver knowledge of nurturing care. The outline, the background. This is the geographic and population information about Indonesia. We have more than 17,000 islands and with multi-ethnic country, over 1,300 ethnic groups. We have a target for pregnant women every year about 4.9 million, and target for under 5 population 22 million. This is the condition about infant mortality rate. For the last data in 2020, our infant mortality rate are 16.85 per 1,000 births, and our target in 2024 is 16. And for the under 5 mortality rate, the last data in 2020, 19.83, and our target in 2024, 25 per 1,000 births. For the integrated child health checkup, the approach with nurturing care framework from WHO is there are good framework for good health, adequate nutrition, and responsive caregiving, security and safety opportunities for early learning. We have policy foundation in Indonesia. There are law number 17 about concerning health, and also we have presidential regulation concerning the acceleration of stunting reduction, and we have Ministry of Health regulation about concerning child health effort, and Ministry of Health regulation about concerning technical standard for the fulfillment of minimum health services. The Ministry of Health commitment to transforming Indonesia health system. There are 6 pillars of transformation from number 1, primary health care transformation, and then secondary care transformation, health system resilient transformation, health financing transformation, health workforce transformation, and health technology transformation. Under 5 health services, according to standard, become one of the indicator of minimum service standard in health sector. There are 12 indicator for minimum service standard. The target for the district must reach 100% to reach the indicator. In number 4, there are indicator every child under 5 get health services according to standard. It meaning the prevention of toddler nutrition problem is carried out through routine monitoring of toddler growth and development as part of the minimum standard. And if there are indication of growth failure or growth development, must referral and immediately to health services to confirm about nutritional status and further intervention. This is the implementation for integrated child health check-up model in Indonesia. It began at 2019. we need assessment, and then model development. After that, we develop guideline and also orientation module. And in 2020, socialization and orientation. And we use there are baseline survey before pilot activities. And in May until December 2022, we organize pilot activities in 2 districts, and then online survey. In 2024, nationwide dissemination. At October 2024, we orientation all provinces in Indonesia. There are 38 provinces, and in 2025, we will scaling up this program to the national program. What is integrated child health checkup? This is integrated monitoring and screening activities of health, growth, and development of children using maternal child health handbook. Its priorities with promotive and preventive concept. The target is infant at 6 months of age and can be carried out at primary health facilities, or in Indonesia we call puskesmas, also in the village hall or other following the local condition. 1 until 2 times per month regularly, with around target 25 target per time, or also it conditional in for the target in the area. Okay, this is the step. There are 6 steps to integrated child health check-up. Step 1, the children registration with health worker or community health worker. And then step 2, initial assessment and developmental screening. And step 3, growth assessment with anthropometry with health worker. Step 4, clinical examination with the doctor. And step 5, individual counseling, immunization or vitamin A services, and also group counseling. And step 6, conference with all implementing staff. This is our piloting. The piloting in April 2022 until December 2022. We conduct in Surakarta City and in Sleman District. The total number of children who participate in the piloting, 1,486 children with attendance rates 75% from the target. And there are 1,361 children have received follow-up action, and 1.3% receive referral, and some referral cases carried out during ICSC include development problem, 6 children, growth problem, 5 children, and clinical problems such as dermatitis, hernia, and micropenis, 13 children. We organize survey before and after the piloting, and for mother or caregiver knowledge about nutrition, growth, immunization, and development stimulation, and responsive parenting increase after participating in ICHC. We can see the data before and after participate in ICHC, and also caregiver practices in providing stimulation from responsive parenting have significantly improved when comparing baseline and online survey. Many benefits for ICSC. For the family, get comprehensive health services, increase knowledge about children's health, improve parent ability in parenting to fulfill optimal health and child development, and get immediate treatment if health problems are found in children. And for community health worker, knowing the health condition of children in their area of responsibility and playing an active role in creating health families increasing knowledge, increasing skill from community health worker in filling out maternal child health handbooks. And for health worker, knowing the health condition of children in the work area, detecting and providing early management of illness or disorder in children, evaluating the provision of exclusive breastfeeding, immunization, and vitamin A, increasing the knowledge and competence about health, nutrition, growth and development, responsive care and safety, and also increasing the completeness of filling out the maternal child health handbook. We have support from many stakeholders. From the central, we get land and then regulation, socialization, orientation, and also the support from professional organization with pediatrician and also with medical and assisted the implementation of ICSC in the target area, or also collaborate with head office in conducting facilitative orientation and supervision on the implementation of ICSC. And also we have support from province or district, city, and from development partner from JICA, from WHO, UNICEF, and etc. And from support from primary healthcare and health facilities. The conclusion, ICSC aims to support the optimal growth and development of early childhood. The Ministry of Health has officially adopted as a national program and will implement it in nationwide. The purpose is this pilot is to identify operational challenges, to redesign in ICSC to redesign the model and develop strategies for national implementation. Finding and implication during the monitoring of the pilot, mother gave positive feedback and health worker expressed the benefit of providing multiple services in a single visit. Some challenges were also identified, such as difficulties for caregiver in assessing implementation state, increasing workload for health personnel, and difficulties in securing budget. Because ICSC has a good impact on every level of benefit, so Indonesia will scaling up to be a national program at 2025. Thank you very much. Arigatou gozaimasu. Terima kasih.
Thank you very much for that experience from Indonesia. I think it just shows that something can be done. And it's good that the country has learned lessons and having strategies to actually address them. So let's go to the next presenter, Dr. Nakatamari, who is going to show the video.
My name is Keiko Saki, as an advisor on health, as a part of the organizer. So let us allow to roll the video of Dr. Saki Nakamura. So because she is connecting, but unfortunately, she may not be able to keep connected while until the session. So that's why allow us, on behalf of her, we are rolling the record of her presentation. But if you have any direct questions, we can get it and then to send her the email, and she will try to respond to you. Thank you. So please go ahead.
Hello, my name is Saki Nakamura, Deputy Director from the Maternal and Child Health Division of the Children and Families Agency, the Government of Japan. Today, I would like to speak about the child health checkups in Japan. We believe these checkups are very important in promoting infant and child health. Our agency was recently established in 2023 with the slogan of Children-Centered. We strive to actively hear the voices of children to reflect them in our policies. Our agency consists of one secretariat and two bureaus. The Maternal and Child Health Division is placed within the Child Development Bureau and provides support for pregnancy and childbirth and maternal and child health, and formulates basic policy on child care and development. This work was previously done in the Ministry of Health, Labor and Welfare. The Support Bureau provides support for children and families with various difficulties and develops policies regarding prevention measures against child abuse, suicide, and bullying. In Japan, we have the Basic Act on Children, which was enacted from April 2023, simultaneous with the launch of the Children and Families Agency, to comprehensively promote child-related policies with a view to realize a society in which all children are able to grow up equally in good mental and physical health as independent individuals, have their rights advocated for, and live a fulfilling life in the future, regardless of their physical and mental conditions or circumstances. As basic information, Japan's population is about 125 million, living in the area over 378,000 square kilometers. We have the central government, and at the very local level, there are 1,741 local governments, which are municipalities and special wards. These municipalities and special wards belong to prefectures, and there are 47 prefectures in Japan. As you may know, Japan is known for its population's long life expectancy, and we also have a very low maternal, infant, and perinatal mortality rate. This is the last introductory slide showing the overview of maternal and child health related measures in Japan. The very first contact opportunity with a child is the newborn baby visiting consultation, where a physician, public health nurse, midwife, or other staff visits the guardian of a newborn within 1 to 2 months after birth and gives necessary guidance when it is deemed necessary for child care. The second opportunity is visiting consultation services for all households with infants, provided within 4 months after birth. After then, there are scheduled health checks that take place at key milestones. Maternal and child health related measures in Japan are based on the Maternal and Child Health Act, which was enacted in 1965 in order to improve the maternal mortality rate that remained high. Efforts were made to strengthen maternal and child health related measures, including providing health checkups and health guidance. The objective of the MCH Act is to promote maternal, infant, and child health by identifying principles of maternal and child health and implementing health guidance, health examination, medical care, and other measures. The newborn baby visiting consultation and health examination are implemented based on Article 11, 12, and 13 of the Act. It is an obligation for municipalities to provide physical examination to 18-month-olds and 3-year-olds. Additional physical examinations shall be provided as necessary. This slide shows lists of items that are checked at 18 months and 3-year-old checkups. Participation rate of these health checks are 95.2% and 94.6% respectively. Most municipalities conduct additional health checks. All checkups, whether they are voluntary or mandatory, are subsidized by local allocation tax, where the national government adjusts the imbalance of financial resources among local governments. Implementation rate of the 2 mandatory checkups are almost 100%, and they are either implemented as group checkup or individual checkup. The Maternal and Child Health Handbook, which is issued by municipalities as per Article 16 of the MCH Act, plays an important role in maternal and child health in Japan. It is a consistent health record regarding pregnancy, childbirth, and childbearing. Records of health checks during infancy and early childhood is a mandatory item in the MCH Handbook. This slide shows the full contents of the MCH handbook for your reference. This is a flowchart which may be helpful to visualize an example of a 3-year-old group checkup done in Japan. First, a notice from the municipality arrives to the family's home when it is time for the checkup. The guardians answer a questionnaire which will be collected at the checkup. Then, the child visits the local public health center with his or her guardians on the designated date. Other children of the same age will also be visiting the center on the same day. A public health nurse at the public health center checks the questionnaire and the maternal and child health handbook filled out by the guardians in advance. The nurse interviews the guardians and the child to gather further information about the child and the child care environment. Dental checkup, eye examination, and a physical examination will be performed. The results of the checkups are recorded in the MCH handbook and the health examination form. Some municipalities hold post-checkup conferences where information about children of concern is shared, leading to support as needed. Finally, I would like to introduce some of the recent projects for infant health checkups in Japan. Currently, the government is conducting a 1-month and 5-year-old health checkup support program to establish a system that provides uninterrupted health examinations from birth to preschool age by subsidizing the cost of health examinations for 1-month-olds and 5-year-olds. In many municipalities, there are no health examinations that take place after the 3-year-old checkup until the health examinations for children starting school. We ask 5-year checkups to be conducted in groups as it is more appropriate to examine social behavior. These checkups are subsidized by the country and the municipality. It is important to have a local follow-up system that leads to necessary support when findings are recognized at the 5-year-old health checkup. We are trying to resolve issues such as appropriate training of physicians that perform the checkups and capacity building of medical institutions. There needs to be a stronger collaboration between developmental support centers and MCH care, and the welfare support system has to be reinforced. Information sharing needs to be effective between nursery schools, kindergartens, schools, and boards of education. Individualized support and attention can only be provided when there is a stronger collaboration between education, health, medical care, and welfare. This is the end of my presentation. Thank you for listening, and I am more than happy to respond to any questions.
Thank you, Dr. Nakamura. I know you're online, so you are hearing. We have heard your presentation loud and clear, and has given us really a good overview of what is happening in Japan here. I think the lessons I've learned is one, nothing can happen without a good environment. So the act was very, very important. And also the fact that they are mandatory. I think that's another message I've heard from you. And also making sure that there's no barrier to accessing the services. So we shall move to Indonesia, to Thailand for the experience from Thailand, from Dr. Surat. Thank you.
Good morning, everyone. My name is Dr. Surat Piusawang. I am a developmental and behavioral pediatrician working at the Department of Health in Thailand. I'm honored to be here today to share insight on early childhood care in Thailand, particularly the role of the social sector and primary care in promoting the health, the well-being, and well-being of preschool-age children. Overview of early childhood care in Thailand. In Thailand, we place a strong emphasis on preventive health service, health promotion, and comprehensive child development starting from the preschool years. This approach involves collaboration between various sectors and communities. The role of social sector and primary care. Social sector involvement in Thailand, the care of young children is not solely the responsibility of government. The social sector plays a significant role with community child care center and local health volunteers contributing to child care service and health promotion activities. In the primary care service in Thailand have 3 doctor projects for solve the doctor shortage. In the call in Thai, 3 หมอ 3 is in English is 3 หมอ in Thai is a doctor. The first doctor, local health volunteer is the first doctor, and the second doctor, healthcare provider, example, nurse in sub-district health promotion hospital, and 3 doctor, the medical doctor, the family medical doctor in hospital. Primary care is at the heart of our child health service. This includes growth monitoring, immunization programs, and regular health checkups. Health center and family doctor ensure that every child receives essential care, and they work closely with families to provide health education and counseling. Partnership with Ministry of Education. The collaboration between the Ministry of Public Health and the Ministry of Education is essential in promoting child health in schools. One key initiative is the Health Promoting School Program, which integrates health education, nutrition, and physical activity into the school curriculum. Teachers also receive training on healthcare, focusing on physical and mental well-being. Successful initiative, for example, our school health program conduct regular health screening and deliver comprehensive health education to children from an early age, helping to identify and address potential health concerns before they become more serious. In the technology supporting health literacy and accessibility, role of technology in Thailand, technology plays growing role in improving access to healthcare and enhancing health literacy among parents and caregivers. Digital platforms such as mobile application and online resource provide parents with easy access to information about child health and development. Example of innovation. One example is the Health Book app developed by the Department of Health, which offers valuable information on maternal and child health, including vaccination schedules, growth tracking, and child development milestones. In addition, telemedicine services have been introduced, allowing families in remote areas to consult with doctors without having a travel long distance. In the Health Book app, which is developed by Department of Health, the format of the Health Book for each age group has been adjusted from paper to digital. It is divided into 4 age groups: maternal and child, school age teenager, working age people, and the elderly. The maternal and child section are what we call the Pink Book for short. In Thailand, developed since 1985, will contain information about pregnancy, health information for infant and young children, such as growth, development, vaccination, and information for sending to school. This slide is example of health book app layout. When a user log in, the app automatically select the age group of the user. For example, a pregnant woman will be taken to the pink book section, which contains complete information about the maternal and child. Limitations and gaps for current development include identity verification of children who do not yet have national ID cards. Who can access children's information? Should it be only the mother, or should it be other people involved in caring for the child? Data recording for medical personnel is still incomplete. Connection to hospital system and connection to other health apps. Future development plans. After launching the HealthBook app last year, the Department of Health aims to reduce the use of traditional paper books and promote the use of applications while developing the app to connect to hospital system to reduce redundancy in data entry. Conclusion, the key takeaway, in summary, the promotion of health and well-being among preschool age children in Thailand is a collaborative effort involving the social sector, primary care service, and partnership with other ministries such as the Ministry of Education. We are also leveraging technology to improve health literacy and make health care more accessible to all. Looking to the future, we aim to continue strengthening this collaboration and innovations, ensuring that every child in Thailand has access to quality health care and the resources they need to thrive. Thank you.
Thank you very much, Dr. Surat. I think you have given us another perspective from this, how you have approached it and showing the collaboration that is required across sectors. And I think this is quite a good example. And also, how can we leverage technology today to actually improve access and information and data flow for continuity of care? I think that's very important. And if you are going to give a perspective for over 20 years, then you need to have somewhere information is recorded. Thank you very much. So this has been an exciting program. I hope people will agree with me that these were really good examples. So now let's hear from somebody who is going to help us put all this perspective together. Ms. Tomoko, please go ahead and just give us some perspective of what you have also experienced from the two perspectives, I think from Indonesia and also part of work I've done here in Japan. Thank you.
Good afternoon, I'm Tomoko Hattori, and I worked with the MCH project in Indonesia until just last month. I'm working with the Dr. Ningram for the HCHC program implementation. Thank you all presenters for the detailed and explicit presentation about the scheduled well-child visit in respective countries. I will try to summarize along the line of the operational components of well-child visit. I will also add some information in Indonesia. Let's start. Japan has a new newborn visit programs and various child health checkups that started in 1960. Checkups for children 18 months and 3 years old are obligatory for municipalities, and other checkups such as 1 month to 3 months, 9, 11 months, and 5 years old voluntarily. But the many municipalities implement those checkups. Indonesia also has a newborn visit programs for checkups for the examination is required, recommended. And then the integrated child health checkup that presented by Dr. Ningram. Actually, we have, Indonesia has other programs that is, the one is the famous one of Posyandu program, which is the monthly, the older children under 5 years check up, check the scale weight at the hamlet level. But it's mainly like consists of the anthropometry, the weight and the height checkup, the measurement, and only 1 or 2 health workers working at the Posyandu level. Then the other one, it's called the program SDID TK, SDID in Indonesian, the stimulation, early detection, and early intervention of child growth and development. This is implemented for 6, 9, 12, 18, 24, 36, 48, 60, and 72 months old children. It's focused on a growth and developmental checking only. So it's still like in terms of integrated, it's less than the ICHC. And right now, the Minister of Health is trying to integrate the consolidate those 3 programs to be in line with. I understand that Thailand has implemented the wheelchair clinics at the 9, 18, 30, and 42 months old since 2015. And also, I'm sorry, I should add like a school age. Is that every year, the school age, And also the Japan also do the school checkup, school student checkup every year. Well, a little bit shortage of the information about Thailand. If you can add some more detailed information about child checkup in Thailand later, we appreciate it. And so this is what I was talking about, the Indonesian system. Those 3 programs gonna be integrated. Looking at the method of implementation in Japan, 4 months, 18 months, and 3 years. 3 years checkups are often conducted as a group at the public health, usually public health centers or civic halls. Other checkups are often conducted individually at the private clinic or the hospital, the outpatient clinic. And hospitals and the private clinics are later reimbursed the expenses by the municipality for the fee for conducting the child checkups. The budget is created from the local budget as presented by Dr. Nakamura, and also local allocation tax from the central. And I have heard that the Thailand, the wheelchair clinic is done on an individual basis. Is that right? Individual, right? Yeah, all right.
Okay, in Indonesia, as of now, everything is implemented by the group, mainly at the PHC center or it's the sub-center. The budget is addressed by each district and special allocation fund from the national budget. In fact, until 2024, the ICHC was not yet becoming the national program. So it was somehow a little bit difficulty. We faced spending the national budget on ICHC, but this is going to be resolved in 2025 because it becomes clearly will be mentioned as items that you can spend from national budget. In the future, yeah, this is important. If the national health insurance can apply for child health checkup, reimbursement will become possible, which will facilitate implementing the ICHC at the private clinic or hospital also, and as well as the motivating the PHC center staff to implement ICHC. Regarding national health insurance, the capitation fund could theoretically be used in the current system, but it is pretty competitive with the other programs, so it's pretty considered as a little bit difficult. So in the future, as possible, apply for the non-capital. Okay. Indonesia, okay. So in connection, looking at the human resources. In Japan, pediatricians are contracted by the hour in cooperation with the Medical Association, Pediatrician Association, and hospitals. In addition, psychotherapists and midwife, nurses, dentists, and sometimes nutritionists are also hired on hourly contract basis from outside source, while public health nurses are from public health centers. Large portion of the budget of the child health checkups in Japan is allocated to those labor costs. In Indonesia, the budget is not allocated enough to hire outsourcing. So the public health primary health care center staff conduct the ICHC while performing their other duties. So since the ICHC is not covered by insurance, the PHC center staff feels like the ICHC is adding another program to complete, and their burden increase, but their income doesn't increase. So even though they understand enough that ICHC is benefiting and it's important, but the motivation can be low. So it is kind of important to think of raising the motivation for them. Okay, one innovation is Indonesian Pediatric Society Pediatrician Social Responsibility. It's in place since 2023. So the pediatrician, they help a lot, play the central role for the orientation, for ICHC, for health personnel, and also the supportive supervision. The component, the Japan and Indonesia, looks like covering as WHO recommendations. And the tools, the 3 countries all use the MCH handbook. For the identification of the target population, Japan use the registry, the residency registry, and Indonesia also use, but especially in an urban area, they had faced a little bit of problem because the actual living address is not according to the registry. Now they start using the database, community-based database. So the aim of this session is to share the experience in implementing a well-child visit with each country, and share the experience, what the struggle, and what kind of the solution worked. So please. Feel free to ask questions each other and discuss. Thank you.
Thank you very much for helping us put all these things together in a very clear way. I think that helps very much to think of what are the aspects that you should think about if you are going to implement. I think we have done a lot of the talking. It's now time to hear from the participants, to ask questions. And to help us manage this process is Anna Robbins, who is a senior health advisor with UNICEF, who is going to help in coordinating the discussion. Thank you. And over to you.
And thank you to all the presenters. What a rich afternoon as we hear about how to plan and manage workforce and health systems to realize that shift to the life course. It's far more complex than you would imagine. So I'm here to take questions and hear from you. So would anybody have a question that they would like to ask? Wow, lots of questions. That's great. Perfect.
Moment, maybe my colleagues can come and sit here so that you can respond.
It's very inspiring. So it's unfold because usually we're discussing about the traditional issues about newborn deaths and about survival. So now we're changing. So this is this is a reflection from 2 countries and also how we bring it global wide. How we will support and provide technical assistance about the transition. And at the time the country would like to add another program. Because for example, the country who's still fighting with survival issues, I think they will focus on the program of survival. At the time, they will change to thrive. I think with this child checkup integrated, this is more focused about the 2nd and the 3rd phase, thrive and transform. So how we will support these countries to face this transition process smoothly, and at the time they will add another program into their system. Thank you.
Thank you. Could you introduce yourself?
I'm Beth from Indonesia. Thank you.
Fantastic. Thank you, Beth from Indonesia. Let's take a few questions and then we'll ask the panel to respond.
And thank you, Dr. Surat, for your nice presentation and also your sharing of experience in Thailand. So I have a small question. Maybe you can share a little bit about how you collaborate with the Ministry of Education, and you also mentioned that you train the teachers to do the monitoring of child growth and development. Maybe you can share about that one, because in Indonesia we also collaborate to Ministry of Health, but the practice is done by the health worker. So maybe you can share the experience in Thailand. Sorry, I'm Andit from Indonesia. I'm also a pediatrician. Thank you.
I'm Anindya Chaudhary from IDRC Canada, but I'm coming from the New Delhi office. Thank you so much to all of the presenters for the excellent conversation. Dr. Vere, the whole point of this discussion was, I think, that countries, in order to actually improve child health over the long term, so there needs to be sort of a continuity between and parity between policy strategy implementation. It has to be done over decades, in fact, right? And it's for example, I noticed in Dr. Nakamura's presentation that the foundations of the Japanese system were laid in 1938 to 42, when Japan was fighting the biggest war in its history, right? So as you can understand the focus on systemic approach. So this is the perspective I'm coming from, and I have a question for Dr. Ningrum and one for Professor Surat. So Dr. Ningrum, you mentioned almost in passing that the challenge is now is that one of the obstacles is that increased workload for the health workers and difficulty in securing budget. Now, I'm actually interested in finding out how you're solving those challenges. I mean, because those are challenges every country on earth, especially developing countries, are facing, right? So that's one thing. And sort of like a similar question for Dr. Surat is that in Thailand, this parity between policy, strategy, implementation. The politics of Thailand is oftentimes interesting, whereas the child, or not just child, the medical system of Thailand is perhaps among the best in the developing countries, right? How exactly do you almost disentangle the politics from the implementation and the system? So what is the country approach? So I would be very interested to hear that. Thank you so much.
We'll just take one more question and then we will turn to the panelists for the answers.
Thank you very much. I am from Bangladesh. I am an obstetrician and gynecologist. So thank you for the presenters and all the audiences. As you know that the MCA's handbook that has been introduced in our country from last decades, but we have seen some gaps that I want to just share with you. Only 2-3 points that is related to my last presenter's presentations, because she showed the child visit programs in different countries following the WHO recommendation. My question was that as you know that some of the developed countries or like our developing countries, those who are still facing the problem for the routine antenatal care, according to the WHO recommendation, how could we integrate this child visit to the pregnant mother during their ANC visit? That would be more meaningful and impactful for to implement this child visit also. So should we think on that because we saw that the ANC visit is not done perfectly, and standard ANC visit is very much lacking in like our countries, developing countries, where to integrate the routine child visit programs after the delivery of the baby. How we will think on that? Thank you very much.
Thank you very much. Let's answer these questions first before we move to the next round. So what I heard was, how will we support the transition from survival to thrive? How can we work with teachers? That was specifically for Thailand. How do we manage the budget increase necessary, especially with the political environment? And how do we integrate the child visit with ANC to make the absolute optimal use of resources and systems? So would each panel member like to comment? Would you like to start? Do you want to come here, or are you okay there?
In the issue of the training with the teacher in school, the Ministry of Public Health and Ministry of Education is the sign in MOU for the collaboration for the healthcare sector to the teacher, and share in the part of parenting and healthcare in the increased health education and health literacy for the teacher to implement the child. The problem vary in the school. In the private school is the in the interest this for the health problem, but the local and the distant school maybe not collaboration. The sole problem, the healthcare provider for the active to the all school for the promote the health promotion and health literacy for all school, but now in coverage, not coverage in the 100% in Thailand. Maybe the progression for in the future, hoping to the all school can cooperation with the Ministry of Public Health. In the monitoring, this the gap in the Thailand in the project initiative, but the monitoring and evaluation in the gap for the collect data in the KPI for the Ministry of Health for the coverage, but the not focus in the quality is the only the coverage for screening.
What is happening with us in Sierra Leone? We are working. We have the adolescent health project. So they are working with social welfare and the schools as well. They have meetings and they have school. We already have people working in the schools. Nurses are posted to those schools. Not all schools really. We have started with, I think, the boarding home schools. Nurses are posted there and they stay there to give the education and to even treat when they refer only serious cases. And for the child health, for under fives, what we have done, we have included the milestone, developmental milestone in our handbook, so that the mothers, we teach them at the facility level of all the milestones, starting from the very day you deliver, what you look for. What are the things that is there? I just want to show you the book.
Could you also introduce yourself, please?
I am Mary Fuller. I am the Chief Nursing Officer in Sierra Leone. These are the milestones we teach the mothers. If the child, by 3 months, the child should be able to look at objects. When you pass it this way, they should be able to look at it. If the child fails to do that, then you should report to the health facility. So we have already included that in our handbook. Thank you.
Mm-hmm. Thank you so much for your enthusiasm as well. So shall we continue to answer the questions?
Thank you for your question. Indonesia, besides mortality and morbidities, also we have problem about quality life of the children. So we have many programs for the children for screening. This year, Indonesia have a new president, and the president has a priority program. The name is screening every birthday. So if the people in Indonesia in 2025 you have birthday, Ministry of Health will send message for the person to going to the primary health care to do screening, packet of screening. This is especially for the children too. This is our challenges to increase the quality of life for our children. And for the budgeting, this is still the challenges, I think. Especially for the technical assistant, now Indonesia, we in Ministry of Health make a curriculum and module to growth and development monitoring with pediatrician, with IDAI or Organization for IDAI, and organization profession of pediatrician. The name is IDAI. We make a curriculum module and the training using blended learning. So it is make budget low because for the theory we use Zoom or online, but for the practice we invite via offline. So it make the budget low. And also we have a platform, the name is Pelataran Sehat. It is the platform to have training online for all training in health training can access by health worker via Pelataran Sehat, so they can improve their skill with online. Okay. And we also collaboration with IDAI or Organization Professional Pediatrician with the name Pediatrician Social Responsibility. Pediatrician in the district assistant give technical assistance to medical doctor in primary healthcare, also to nurse and midwife, how to treat the child health. And for the Indonesia, for the neonatal, minimal contact to facility 3 times. And it covered by national health insurance. And so they can free when coming to contact in neonatal, in neonatal. And for ICSC, because this is the new program, this is not yet covered by national insurance. This is our challenges, how to the program covered by national insurance. Okay, thank you.
Thank you so much. Thank you for answering. Does anybody else have any questions?
I'll give some response for somebody who asked a question around how shall we provide technical support to transition. I think there's no transition. I think we sometimes we misinterpret some of the things. One, what is thrive and what is survive? Will you call immunization survival or thrive? So I think when you look at it that way, there's no period where you are saying you are going to transition from this to that, because all of them are actually making this child, they might say it's a thrive agenda, but it's actually building resilience in that child to survive. So I think if you approach it from that perspective, nutrition is very important for child survival. The mental health is very important for child survival. So it's very important that we don't split these things. Yes, you can struggle to put them in place, but they're actually critical and important. I just wanted to emphasize that there's nothing, say, you'll finish the survival agenda and reduce. No. You should actually build resilience. You may actually act faster. If the mother knows that hygiene is very important for the child not to get diarrhea, then you will not get diarrhea to die of diarrhea. So I think we need to think like that. There's no just that we finish this aspect of survival and then we move to thrive. There's no transition. I'm just trying to say that. And actually it's a big problem. We need to address it now, because any major differences we are going to make is going to come from that investment, rather than waiting when children are sick and you are struggling to make them survive. Thank you.
Thank you very much. So we have a question over here. Please remember to introduce yourself at the microphone when you get there. Just as you're walking around, I'm going to jump in and take the liberty to ask my questions as well. So my question is around empowering mothers. Are you finding that it's this method is an ability for empowering mothers to ask questions and have a dialogue with health workers? My second question is about digitalization. has there been an accelerated effort to digitalize the recording of these events? And then quality, the booklet's only as good as how it's completed. How do you get it completed thoroughly? I apologize if I asked one of your questions.
No, actually no. Thank you very much. I'm Akira Shibanma from the University of Tokyo. My question is about the guidance, the virtual guidance itself. So especially for adolescents, so 10 to 14 years old ones and 15 to 19. So once again. So however, as we all know, the adolescent has a very important transition period for physical and mental health. And we all know that so the speed of transition and timing are different. So among each individual. So how to ensure that the adolescents can have an appropriate access to the good or well-care visit, so in this framework. And so in many countries, psychosocial issues is very difficult to address in the adolescent health. So what kind of resources development is required to ensure that the well-care visit is secured for adolescent stage? Thank you very much.
Thank you. So panelists, would you like to answer the questions around appropriate adolescent friendly? Or are you going to?
I'll just speak on the guidance, like you said. So this is always a big thing. We can be at global level and make guidance. And remember, I said these are minimum. I just want to stress, that's why I said these are minimum visits. We looked at what is the minimum that you can do, and it's based on exactly the same things we are saying, that between 10 and 14 years, you really need, there's a transition there you really need to address. And then after 15 to 19, there's also real transition you need to address. So that's just minimum. So depending on the context of the country, you can then define, depending on whether you have the platform that can deliver the interventions and what you want to deliver, what interventions you want to focus on, and then you can decide whether you need 2 more visits or 3 more visits. But I will tell you that when we release the guidance, everybody said 17 visits? This is too much. And the question you're asking has come several times, every time we share about this, because people actually feel there should be more visits. But we also want to make sure that the systems are able to do it. It's not just putting the visits. You should put those visits knowing that there's reason why you are going to do them, and actually they are going to be impactful when you do them. Thank you.
Thank you. Kiko-san, do you have anything to add? No remarks. Okay. As panelists, maybe you could also help us with how much time we have left. 4 minutes. Okay, thank you.
For that age below the adolescent. And the handbook has captured that already for us. Thank you.
Thank you very much.
Next time I'll do this.
Okay.
Thank you.
Thank you very much.
And the infrastructure. We are talking about all these things. But what we work with and where we work is a challenge when you go to the front lines. Thank you. Let's also think about that. How WHO, UNICEF, and our governments, left them there, should help us improve our working environment.
Yeah, we have the system support for all this underneath, don't we, in terms of infrastructure, staff, supplies, money, time. So panelists, I asked about empowering mothers and digitalization. Would anybody like to comment on that?
And I told them, but this is a home record. Not every home in Sierra Leone have a cell phone. So if you are going to put their records in cell phone, that means you'll be leaving, let me say, 1/10 or so people out. And there will be people who will not be able to even read what you put into the phone. So the home-based record is there for the families we can digitalize our system, no problem. But the book stands the test of time. Thank you.
So while you're at the microphone, could you also talk to the empowering mothers? Do you think the booklet empowers mothers?
In fact, it is the working tool of the mothers. Now they can see with their naked eyes, especially in our book, we did more of pictures so that our illiterate mothers will be able to relate with the book, to learn from it, and they can now ask questions with the health workers to ensure that they take care of their pregnancies, not only the babies, start with the pregnancy, and then on to the growth of their children. Thank you.
Thank you so much. So just to close off the session now then, just to give a big thanks to everyone that's organized it. A lot of work's been gone into this for WHO, JICA, my colleagues in UNICEF and the panel, government, and all of you who've participated. I know the jet lag is really hard in the afternoon, so just another round of applause for yourselves.